guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about adrenal neoplasms. There's a lot of endocrine neoplasms, but I wanted to include specifically the ones that target your adrenal gland here in this video, since this is our adrenal chapter, and I think it'll be helpful for you guys to group these in your head when you are thinking about these pathologies for step one. So first, let's talk about pheochromocytoma. Pheochromocytoma is going to be a neoplasm of the adrenal medulla. The neural crest cells inside the adrenal medulla are what are going to develop into the chromaffin cells. Those chromaffin cells are what secretes epinephrine, norepi, and dopamine. When we have abnormal proliferation of our chromaffin cells, that is going to lead to increased epinephrine, increased norepinephrine, and increased dopamine. All of these we call our catecholamines, and when you're thinking about all these different hormones, epinephrine and norepinephrine specifically, I want you to think about them as our fight or flight hormones or our sympathetic activators. And if you think about them in this sense, that should make sense to you when we talk about the presentation of pheochromocytoma. So if you're in fight or flight mode where you have a lot of sympathetic activation, that is going to lead to hypertension, sweating, so diaphoresis, tachycardia, so increased heart rate, pallor, and potentially headache. So all of these things are the presentation of pheochromocytoma, and I think that just makes sense if you think about what's being secreted. Pheochromocytoma is the most common tumor of the adrenal medulla in adults. Neuroblastoma, which we'll talk about next, is going to be the most common tumor of the adrenal medulla in children. And then some important associations of pheochromocytoma is often one of the outcomes of these genetic disorders such as neurofibromatosis type 1, von Hippel-Lindau disease, or MEN2A and MEN2B. So also keep in mind that all of the symptoms that come with a pheochromocytoma may be part of the presentation for any one of these genetic syndromes. 10% of pheochromocytomas are malignant, so that's pretty low, they're usually benign, and then 10% are going to be bilaterals. Now before we get into the diagnostics of pheochromocytoma, I want to quickly recap a basic pathway for the breakdown of our catecholamines. And keep in mind, this is by no means an extensive depiction of this pathway. It's kind of the bare bones. So we start out with norepinephrine, and then enzymes like K.A.N are going to break this down into norepinephrine, and then another enzyme, MAO, is going to break this down into vanillymandylic acid, and vanillymandylic acid is going to be one of those breakdown products that can be seen in the urine. Similarly, for epinephrine, epinephrine can be broken down by K.A.N. K.A.N can make this into a metanephrine, so norepinephrine for norepi, just metanephrine for epi, and then MAO comes along to make this metanephrine into vanillymandylic acid, which of course can be secreted in the urine. And I just included this pathway here to jog your memory because I think it's important to help you understand why we're going to see increased urine metanephrine's in the setting of pheochromocytoma. If we're making a ton of norepinephrine and epinephrine, and metanephrine are going to be breakdown products of these catecholamines, then it should make sense to you that we'll see more metanephrines excreted in the urine. We will also see more metanephrines just floating around in the plasma, as well as catecholamines. And then if you biopsy one of these tumors and then you send it for histopathological staining, you might see increased chromogranin staining and synaptophysin staining. These are going to be stains that are commonly used for neuroendocrine cells, and since this is a neuroendocrine tumor, it will stain positive for these, so that's going to be an important diagnostic piece as well. And then finally, CT or MRI of the abdomen should show these masses, and that is going to be your pheochromocytoma. Management of your pheochromocytoma is going to include alpha antagonists, so things like phenoxybenzamine, and then subsequent use of beta blockers like propranolol preceding tumor resection. So why is it important to use alpha antagonists before beta blockers? Easy to remember that A comes before B, and pheochromocytoma should be treated with phenoxybenzamine. But what's the actual physiological significance of this? Well, it's all about blood pressure. We are trying to avoid hypertensive crisis. So we use our alpha antagonists first because alpha antagonists go to the vessels and they combat the action of norepinephrine. Norepinephrine is trying to constrict these vessels, and alpha antagonists prevent this from happening, so they are going to have dilation, which will lead to a decrease in systemic vascular resistance. By contrast, beta blockers, while they're great at slowing the heart rate down after we've already decreased the systemic vascular resistance, they have the effect of increasing tone at the vessels. So if we gave someone a beta blocker first and they had a pheochromocytoma, this would down the effects of epinephrine and norepinephrine, increase systemic vascular resistance, and then cause a hypertensive crisis. So very important that you give the alpha antagonist before the beta blocker. A comes before B, and only once the pressures are controlled can you consider this patient for tumor resection. Now the next neoplasm I want to talk about is neuroblastoma. Neuroblastoma is also a tumor of the neural crest cells in the adrenal medulla, and And amplification of the N-MYC oncogene leads to development of this tumor. This tumor can occur anywhere along the sympathetic chain. So it's not just limited to the adrenal glands, not just limited to the abdomen. Anywhere the sympathetic chain runs, you can have this tumor. Symptoms are going to be abdominal distension, a firm mass that crosses the midline. This is going to be an important factor because if you see a kid with a firm mass that doesn't cross the midline, that would be suspicious for Wilms tumor. However, if it does cross the midline, that's more suspicious for neuroblastoma. These patients may also have opsoclonus myoclonus. It is the most common tumor of the adrenal medulla in children. Remember that pheochromocytoma was more common in adults. And then our diagnostics are going to be very similar because we still have an increase in all of the catecholamines that go through the catecholamine breakdown pathway, and that will lead to increased urine vanillin mandelic acid or homovanillin mandelic acid. On histopathology, you might see these homoryte rosettes. So if you look over here, you can see these central areas of hyalinosis and then surrounding all of these little cells, and that is the classic pattern of a homoryte rosette. This is not specific to neuroblastoma. It's also seen in medulloblastoma, but it is going to separate neuroblastoma from something like pheochromocytoma. It will stain NSC and bombesin, and then you can treat it with resection, chemotherapy, and radiation. And then the last neoplasm I want to talk about is adrenal carcinoma. Adrenal carcinoma is going to be a cortex tumor. So C for carcinoma, C for cortex. This is not a tumor of the medulla. It can secrete glucocorticoids, aldosterone, androgens, or estrogens. And all of these hormones are going to be integral to the presentation of adrenal carcinoma. So in addition to abdominal pain, back pain, abdominal mass, you're going to see symptoms of an increase in all of these different hormones. The increase in cortisol will lead to classic Cushing syndrome presentation, so moon facies, dorsal cervical fat pad, muscle weakness, hypertension, hyperglycemia, striae. The increase in aldosterone will lead to hypernatremic hypertension, headache, and muscle weakness. The increase in androgens can lead to amenorrhea in females, increased hair growth and virilization in females, and the increase in estrogens can lead to gynecomastia in males, impotence for males, decreased libido, and then irregular menstruation for females. Important associations here are Li-Fraumeni and Beckwith-Wiedemann syndromes. And then diagnostics are increased 24-hour urine cortisol. This is a potential cause of primary hypercortisolism. You're not going to see any response to the dexamethasone suppression test because this production of cortisol is unregulated. And then you might see an adrenal mass on CT or MRI. Zooming in on the CT image over here, let's quickly orient ourselves. This is always going to be a slice of someone's body with their feet pointing out of the screen or towards us. That is how we know that this is going to be the right side and this is going to be the left side. I always like to start out and look for the vertebra. So this is a vertebral body right here. That's going to help us orient that this is posterior and this is the anterior side. A great landmark that I like to look for in the abdomen is where is the liver. The liver is this large organ on the right side. That makes sense. And then once we see the liver, we can kind of look around and see, can we see a little bit of pancreas that should be more midline? Can we see the aorta that should be right in front of our vertebra? And the kidneys should be symmetrical. You should be able to see one on each side. Here you can see one kidney here, another kidney over here. And our helpful radiologist has given us an arrow sign here. I love a good arrow sign. And it is pointing out to us in this case a mass that is right along the border of this right-sided kidney. So here's the right-sided kidney and we are pointing at this dark spot here. And that dark spot is very suspicious for an adrenal neoplasm because of its proximity to the kidney. Remember, our adrenal glands are also called our suprarenal glands. So when we have a mass that is sitting on top of our kidney or suprarenal, then we can think about possibly an adrenal mass. In this case, this adrenal mass is an adrenal carcinoma, and we will treat it with resection, chemotherapy, and radiation. I know that was a lot of information. Let's quickly recap. Pheochromocytoma is a neoplasm of the medulla. It is the most common adrenal medulla tumor in adults. It'll present with hypertension, flushing, diaphoresis. This can be a really similar presentation to carcinoid syndrome, and these two often get confused. But remember, we're going to have increased urine metanephrines in pheochromocytoma, and this would be increased serotonin products like 5-HIAA if this was carcinoid syndrome. Neuroblastoma will most likely present in a child with a firm mass that does cross the midline. You may see many of the symptoms with pheochromocytoma, and you'll have elevated catecholamine breakdown products in your urine as well. Adrenal carcinoma is a cause of primary hypercortisolism. You'll also see elevated aldosterone, androgens, and estrogens. You may see a mass on CT, as we talked about over here. and you will treat it with resection, chemo, and radiation. So how do they ask you about this on a board style question? Well, a question they might ask you is a 47-year-old man presents for 3 months of intermittent sweating, heart palpitations, and headaches. He has a history of medullary thyroid cancer in remission, but no other past medical history. Blood pressure on arrival is 129/76. During the abdominal exam, the patient becomes diaphoretic and short of breath. Repeat blood pressure is 156/89. What is the mechanism of action of the medication indicated to treat this patient's symptoms? Okay, so our patient has sweating, hypertension, headaches. This could be a presentation for pheochromocytoma or neuroblastoma or carcinoid syndrome, less likely neuroblastoma since it's an adult. We know in his history that he has a history of medullary thyroid cancer. That taken together with possible symptoms of pheochromocytoma really makes me suspicious for an MEN2A or an MEN2B mutation. His blood pressure on arrival is initially normal, but during the abdominal exam, he becomes diaphoretic, short of breath, and his blood pressure becomes elevated. This really makes me suspicious for pheochromocytoma because it's important for you to remember that palpation of this mass can actually increase the release of some of our catecholamines, inducing that sympathetic activity and causing hypertension. Then the question asks us, what is the mechanism of action of the medication indicated to treat this patient's current symptoms? Well, we know that we want to give our alpha antagonist before our beta blocker, so the mechanism of action would be an alpha antagonist, and it would be something like phenoxybenzamine. That's all I have for you on adrenal neoplasms. I hope this video was helpful, and I'll see you next time.